Hey everyone, welcome back to another webinar at integrativelifenetwork.com. I am with my friend, Dr. Daniel Barton, psychiatrist in Nashville, Tennessee. I'll let him introduce himself, but today we're going to be talking about psychedelics and mental health. Now, I want to give a strong disclaimer, and Dr. Barton's going to do so as well, but we're going to be talking about some things that are not legal right now, and we're not encouraging in any way people to do that. Merely, Dr. Barton is sharing his expertise, experience, things he's researched done. He runs a ketamine clinic in Nashville, but we're going to be talking about things that aren't on the legal spectrum right now. And so, as always, anybody listening in, you need to consult your physician, your psychiatrist, your therapist on all these things. This is an informational only webinar, but I'm really excited about what Dr. Barton's going to be sharing today, because this topic, Dr. Barton, is in the news, is in a common conversations. The more and more I hear coming from tech. And so I'm eager to learn and listen too. So Dr. B, thanks for coming back to the Integrative Life Network webinar series, and appreciate you sharing on this subject today.
Well, thank you so much for having me, Cory. And so I'll just jump right in because there's a lot of material to cover. So again, my name is Daniel Barton. I'm a child, adolescent, and adult psychiatrist working in the Nashville area. I work in kind of a private practice setting. I'm also the psychiatric director of the ILC. And I've been running the Nashville Ketamine Center for about 6.5 years. We were the first people in Tennessee and actually the Southeast to have an outpatient ketamine clinic. So I've been doing it for a while and seen some of the changes that have happened over time. And it's been kind of a neat ride. So that is me. And I will echo what Cory said about kind of the disclaimer of the only legal psychedelic in all states is ketamine right now. So that's really, I don't email me and ask for anything because I don't have anything, basically is what I'm saying. And I'm not condoning doing anything. But no presentation on psychedelics and mental health would be appropriate without a nice, like psychedelic background, right? Yeah, am I right, Cory? Yeah.
Yes, sir. You got to have that.
Yeah, you got to have that, man. You got to have that. So these are three guys I kind of wanted to almost like dedicate or thank for this subject matter. On the upper left-hand side is Michael Pollan. And in 2018, he wrote a book called How to Change Your Mind, which was really kind of an important book in this field because it basically made it okay for people to start talking about this. There's so many people out there that have had psychedelic experiences at some point in their life, either in college or older or younger, and don't talk about it. And he kind of made it okay to talk about in public and gave people a language by which to speak about it through his writing and his own experience. On the upper right-hand side is a guy named Rick Doblin, and he's a neat kind of jolly guy. You can kind of tell from this picture, but he is the founder of MAPS, which is the Multidisciplinary Association for Psychedelic Studies. And we owe a great deal of gratitude to him for bringing psychedelics back into the research field through some strategic sort of ways that he went about that I'll talk about later. And then the guy in the lower left, I'll be honest, my wife knows about this. I have a total man crush on this guy. That's Robin Carhart Harris, and he's a psychiatrist at the Imperial College of London and really is responsible for advancing a lot of the neuroscience in this category. And then also, I want to thank our patients because these medicines are largely illegal. Most of what we know, not most, but a lot of what we know comes out of what I would call citizen science. That's a term that I think James Fadiman uses a lot. Personal reports and sites like Arrowhead or Blue Light. And so, and it's also our patients wanting something other than the medicines that we have that are things that they have to take every day with a lot of side effects. So, another kind of important thing in all of this and how we got here has to do with the STAR*D trial. Just to kind of give people a little bit of background, the STAR*D trial was one of the biggest studies that psychiatry had. We had mental health for the medicines that we use, like SSRIs and such. 4,000 people, multi-center throughout the entire United States, really strong inclusion criteria. But it basically treated patients like garden variety psychiatrist or primary care physician would treat a patient. So they come in, they get citalopram, which is Alexa. If that doesn't work, we might switch to Zoloft or Adwalbutrin or CBT. And so this is the decision tree that they used in that study. But the data from that study was interesting. And I will tell you, I went into this field, I became a psychiatrist and not a psychologist because it, in those pinches where like I felt like I wouldn't be able to talk my way, or help this person kind of get through this problem. I wanted to be able to prescribe something that would help. And what they found in the STAR-D trial, if you look here on the left-hand side, you'll see when we gave people first-line treatments, only 27.5% of people responded. So basically, first time somebody comes in with depression, essentially a third of the time they'll get better. And that number decreases over time with each subsequent trial. On the flip side of that, with each subsequent trial, the dropout rate increases. So by the time somebody has tried a medication, and remember, these medications can take 3 to 6 weeks to kick in, and then it can take another month or so for that, for us to change doses or something like that, or to cross titrate to another medicine. By the time all that has happened, it's quite a bit of time, and dropout rates are high and remission rates are low. So all of that kind of leads you with like this sort of a feeling, I mean, it's kind of like this is wild. These medicines, I mean, it's not like, if I was an orthopedic surgeon or something, I could just fix it, right? But in psychiatry, unfortunately, we don't have kind of the ability with our medicines right now to do that. And just kind of also a little bit of background, before many of these medicines were made illegal, and most all of them were made illegal, and that was done in the 60s, primarily for socio-political reasons. Nixon made them illegal around the time of the Vietnam War. We had over 1,000 studies on psychedelics. These were supposed to be our main medicine that were going to be kind of like our kind of, not our cure, but our major miracle medication for the future. And so, they were being used and studied a lot in the 50s and 60s, and even there was a freestanding alcohol treatment center that used LSD as its primary main treatment. I think Bill W., the founder of AA, used some of his experiences during his psychedelic journeys to kind of form that group, and some of the tenets, like the emphasis on spirituality and such, come from some of his experiences. So I was talking about that guy, Rick Doblin, and earlier, and what Rick has done is kind of take these medicines from oblivion and brought them back in. But to do that, to convince people like, hey, these are worth studying again, he did something very strategic. And what he did was say, our vets, I think there was a study from, he basically looked at our veteran population. And so there was a study from the VA, and it looked at data of all the vets from 1979 to 2014. And it basically said that approximately 20 veterans a day die from suicide. So, I was just kind of doing some of this research, and I looked at that stat, and I kept on trying to find other sources for this study, because that just kind of blew me away. I mean, it's kind of obvious that trauma and PTSD would be part of that experience, but 20 veterans a day dying from suicide it's madness. So he looked at this population and said, I think I can help this population. And this is not a Republican issue. This is not a Democrat issue. This is a human life issue. How do we help the people that have helped us? And so what he did is he did a study very early on, and he took a population of veterans, and he gave half of them therapy, and half of them therapy, or the control group got therapy, and the other group got a couple of sessions of the MDMA. And what he found was, at the end of this trial, over 75% of people who got therapy, they still met criteria for PTSD, whereas less than 25% of the people that got the MDMA met criteria for PTSD. That's a substantial difference between those treatment effects. And not only was it a substantial effect, but it was a lasting effect. And here you can see over 3.8 years later, this score here, 80, means that they do have symptoms of PTSD. So those numbers drop even after 3.8 years or 3.5 years. The other study, population study that he did, was he looked at people that were dying of cancer. And so, because who wouldn't want to help somebody who's dying of cancer? And so what he did is he designed a study to look at the effectiveness of one high-dose psilocybin session with therapy. And you can see here, these are the placebo groups. After 5 weeks, 32% had improvements in depression, 24% had improvements in anxiety. But in the group that received one high dose of psilocybin, we see 92% improvement. And even after 6 months, still that number is around 79%. In rating scales of anxiety, they saw 76% improvement. 6 months later, 83%. So it's important that these things kind of, not only do they have an effect, but these effects are lasting. And this is after one session. So that's pretty remarkable. It's not a daily medication, no side effects, just one session. And then they've also done studies. This kind of is a, one question that a lot of people ask, and is kind of relevant in the psychedelic community, is like, well, do I have to have a mental health issue to receive treatment? The obvious answer is no, because millions of people try these medicines like around the United States that don't necessarily have mental health issues all the time. But this was a study where he looked at 36 healthy volunteers. Here again, we have a placebo group in gray, and we see here in the blue who received the psilocybin, 75%, roughly 75% increased well-being. Again, over here, about 70% positive behavior changes in the rating scales, and that lasted for about over a year, 14 months. We still see those positive benefits. Also to note about this study is, in this particular study, 67% of folks rated this as one of the 5 most personally meaningful experiences of their life. That's pretty significant when you have 36 healthy volunteers that have had such a meaningful experience, when you think about all the experiences somebody has in their life. So just to kind of move on and talk about, when I say the psychedelics, there's dozens, if not hundreds of them now, mostly synthetic, but there are plant medicines as well. For the sake of this talk, I'm going to be mainly talking about LSD and psilocybin, which are very similar in how they work. I'm going to be speaking about the pathogen MDMA, as well as the dissociative hallucinogen ketamine, which is the one that I have the experience with for the past 6.5 years. But all of these are kind of under the umbrella of psychedelics. So there will be some generalizations I'll be making about kind of all psychedelics, but I'll kind of point out some nuances as well. And if people have questions during the question section about some of the nuances, I can answer some of those. So the big bad psychedelic, I put this slide in there because, like, we're taught to fear these medicines, and we're taught to fear, like, okay, yeah, they're very interesting, but don't get too close, because this dog's going to bite your hand off, right, Cory? And so
this dog for sure.
Yeah, that dog is a dangerous looking dog. He's cute, but he's dangerous. And when you think about the danger of psychedelics, I would ask people to consider some of these facts. 6 people die a day from alcohol poisoning, 480,000 deaths per year, according to the CDC, of tobacco-related illnesses, 47,000 overdose deaths from opioids in 2017, and that includes heroin and fentanyl and medicines like that, but 17,000 overdose deaths just from the opiate prescriptions like hydrocodone, OxyContin, those types of medicines in 2017. Those are a lot of deaths from these medicines. There's never been a documented human death from the direct overdose of LSD or psilocybin. Never been a direct documented human death. And what I mean by that, that's not to say that nobody's ever died while using one of these medicines. I can't say that people haven't, like, walked out in front of traffic or something like that. But if I take too much heroin, I overdose and die. If I take too much cocaine, I may have a heart attack. If I take too much psilocybin or LSD, I have a really weird experience that can last 4 to 12 hours, and then I wake up the next day trying to make sense of it. So I just think that's really important when we're thinking about safety, because that's what drives some of our fears around these medicines is, are they safe? And this is like a cool study that this guy did. His name is David Nutt. He's a guy in England that studies these medicines. He took, this is what he calls a rational analysis of the 20 most common drugs. And he basically, or drugs of abuse, I should say. And he basically looked at the cost to self, the cost to society of these drugs. And he said, you know, and that means, so for example, healthcare costs, damage, families, the police expense, costs like, you know, for traffic accidents, things of that nature. And then he gave them a harm scale. On the left here, it's probably no secret, alcohol is the highest, most harmful drug in this class with a score of 72. And then where are psychedelics? So let me go here. Oh, it's all the way over here, right there, last. So psilocybin, which is when I say the word psilocybin, those are mushrooms or magic mushrooms. It has a harm score of 6, LSD 7, MDMA 9, and I think ketamine is over here at 15. But compare that to alcohol at 72, heroin over here at 55, crack cocaine. I mean, we're really talking about medicines that are just totally different in terms of their safety profile. So I just think that's kind of an important thing to point out. And this is a graph, you might see it says the same thing. It kind of breaks down harm to self, harm to others, and the types of things that he included, like loss of relationships, loss of tangibles, and things of that nature. So Cory was nice enough to send me some of the questions that people were asking, and some people had questions about how these medicines work. And so I'm going to explain it in kind of a way that I explain it to my patients, which is I'm going to start small and then I'm going to get big. And so when we start small, we kind of move in way close. And for psilocybin and LSD, which are very similar, those hit the 5-HT2A receptors as agonists and cause lots of intracellular changes that help produce the psychedelic effect. The important thing to remember here is that the 5-HT2A receptor is a very popular receptor. That's one of the receptors that some of our SSRIs hit. So a lot of times people who are trying to ingest psilocybin or LSD will have less of an effect of their experience because if they're taking an SSRI like Prozac or Lexapro or something of that nature. This gets a little bit more complex with MDMA, but the kind of take home here is that there's just kind of a massive dump of serotonin out into the synapses, and that's kind of the feel-good neurotransmitter in this case. It's actually much more complicated than that, and if we have time, I'll kind of review some of what makes MDMA such a great medicine for the treatment of trauma. This slide is even more complicated. And this is how ketamine works. Now, really, the take-home message here for ketamine is that it works on the glutamate system. It's not the serotonin system, it's not the norepinephrine system, and it's not the dopamine system. What makes that important is a lot of people will come into me with treatment-resistant depression because they've tried a serotonergic agent, or they've tried like Prozac, which would be an SSRI, or Lexapro. They might have tried a serotonergic serotonin and norepinephrine reuptake inhibitor like Effexor or Prestige, or maybe they've tried Wellbutrin and that didn't work, which is a dopaminergic medication. Essentially, ketamine works on a different system. So if I have a patient that's tried like 10 different medications, like a lot of people will be like, oh, well, I'm afraid the ketamine won't work because none of these other medicines work. Well, they're not related. We're kind of visiting a different neurotransmitter system. So that's kind of a cool thing. So let's zoom out one. And when we zoom out, the medicines work this way. They work through neurogenesis and synaptogenesis. And what that basically means, neurogenesis is the birth of new neurons, and synaptogenesis is kind of the birth of new connections between neurons. So axonal sprouting, synaptic remodeling, creation of new synapses, again, birth of new neurons and more connections between neurons. And why is that important? Well, what we see, this is an example of a neuron. On the left-hand side, it's a healthy neuron. And on the right-hand side, we see a neuron that is essentially, this neuron would belong to somebody or an animal that's depressed. You can kind of think of them like a tree, like a big tree during the summertime has all these leaves in big volume. And then in the wintertime, they get shriveled and we see all the branches and stuff. And that's kind of what, when we get neuronal shrinkage, that word just kind of cracks me up sometimes, they look like this. And so the volume of these areas will actually be decreased. So, and we can see this on functional MRI studies, and we can see it on in particular areas of the brain, like the hippocampus, which is the area that we see volume decrease in depression the most. And the hippocampus is associated with things like learning and concentration and focus, and it's part of our limbic system and our emotional system. It's very closely related to the amygdala. And so, it kind of makes sense that when this area that's associated with concentration and memory kind of decreases in volume, that these symptoms we see these parallel symptoms in depression of problems with concentration, focus. I can't seem to remember things. I'm just forgetting things if I'm depressed. And so again, with psychedelics, we see neuronal growth, and ketamine was really the medicine that kind of showed us this initially the most, because, and these pictures are kind of from the seminal studies of this, where on the left-hand side here, this is the control, the kind of depressed neuron, and on the right-hand side here, post-ketamine use, you see kind of these little buds here, which is sprouting of connections between neurons. So we quite literally see it. We can physically see that. And maybe one way to think about this, when people think about neurogenesis and synaptogenesis, if you're every thought has a neuron associated with it. And the more we practice a thought, the more kind of these thoughts get ingrained. If I sit around and I think I'm an awful guitar player over and over and over. I'm an awful guitar player, that gets rutted in. And so when we're kind of growing new neurons, it kind of makes our brains a little bit more malleable. Kind of, I always think about, if you're going skiing, and I've only been skiing once, and the shoulder that's been dislocated has this to thank for. But the if you're going skiing and you're skiing along, and you hit these ruts, your skis kind of naturally go in those ruts. And you can think of neurogenesis and synaptogenesis as like, it's just kind of, you went to sleep and there's like, 5 inches of fresh powder up there that you can make your own pathways on. So let's zoom out again. And this is where kind of like it gets like really kind of cool and interesting. Not that that other stuff isn't interesting. And I will just say the synaptogenesis and neurogenesis, that's a lot of the heavy lifting that ketamine does for as its antidepressant effect. All psychedelics do that, but ketamine does that exceptionally well. So we zoom out, and why do psychedelics work? They work because of this thing here, the default mode network. And the default mode network, it's made up of medial prefrontal cortex, posterior cingulate cortex areas, and angular gyrus area. You don't have to memorize those things, but just know essentially that the default mode network I think of as the kind of equivalent of the neurological equivalent of our ego. And I don't mean ego like I'm so good at this, I mean ego like self. It's the neurological equivalent of our self. We have all these networks that monitor, like our visual network or our cortex, or our auditory network or cortex that are monitoring these external aspects of life. This is what monitors our internal aspect of life. And so what does it do? It's the center of self. It's involved in self-reflection, metacognition, which is thinking about thinking. It allows us to mentally travel back and forth in time, ponder autobiographical events, ponder future problems. And it's active when I'm not doing anything. So right now, my default mode network is not active at all because I'm presenting this. But if I was just sitting here spacing out, which I might do at some point uh, during this lecture, maybe, I don't know. But if I'm just sitting here spacing out, I'm not truly spacing out. I'm thinking about maybe a conversation I got in with my spouse this morning over a bowl of cereal, but I'm thinking about it from my point of view. I'm thinking about this water right here, and I'm thinking I'm thirsty, but I am thirsty. It's about my needs and things of that nature. And it's all the me part, the I part of how we think. It's our autobiography. The other interesting thing about the default mode network is it is also associated. If you had to have like the networks in a pyramid, and we have visual and hearing, or I don't know what order those would be in, but the default mode network would be at the top. It's the part of us that makes us different from other species like apes and monkeys and things like that. It's the networks that has evolved last, and it's also one of the networks that is most has one of the highest concentrations of the 5-HT2A receptors, which are the receptors that psychedelics hit. So, so I think that's interesting. The other kind of aspect of the default mode network, and I think Aldous Huxley kind of put it neatly, although he didn't know what the DMN was at the time, but he kind of said this: to make biological survival possible, the mind at large has to be funneled through the reducing valve of the brain and the nervous system. What comes out the other end is measly, a trickle of consciousness, which will help us to stay alive on the surface of this particular planet. So the other aspect of the default mode network is it's very involved in reducing our lives and our worlds to as simple a message as we can get it to be, so that we can survive and do the things that we need to do to survive. So for example, when I go brush my teeth, I'm not thinking of every single thing that I have to do every single time I brush my teeth, like turn the water on, put the toothbrush under the faucet. I'm thinking about other things as I'm going through that. But my default mode network, which is one of the most energy hungry parts of our brain, has kind of reduced these things down. And it does the same thing for us emotionally as well. And so sometimes very complex thoughts get kind of reduced down into like, I'm just not that good, or I'm not good enough. And sometimes those things get ingrained, like those ruts we were talking about on the ski slope. I included this slide just to show y'all that like this circle over here has different parts of the brain, and using some of the advanced technologies we have now, we can map the connections between regions of the brain. That's how we know kind of the connections between the default mode network aspects. And when we do that, and somebody's spacing out, they will put them in a functional MRI. And here's my man crush again, Robert Carhart Harris. I just wanted to see him again. This is kind of what's mapped out on the default mode network. And this is kind of one of the big pictures that when people are talking about psychedelics, you will see this picture usually, because this is just, it kind of just says it all. But these are the networks, these are the parts of my brain, this is how my brain is connected when I'm just kind of spacing out. And so what do psychedelics do? They take the default mode network and they take it from a volume of 11, if you've ever seen Spinal Tap, and they turn it down to 0. And so they essentially turn off the default mode network. And when you turn off that organized part of our brain, this is what happens. So on the right, we're seeing our brain mapped again. These are all the various networks in our brain, and the connections get much more chaotic. They get much less organized. And it's kind of a different type of consciousness that is much more creative. During the psychedelic experience, people will have something called synesthesia, which is, our senses get kind of mixed. I might smell a color or hear a smell, something like that, because I might have connections that kind of get that chaotic during that experience. So, so we have, again, zoomed in, it hits those neurotransmitters. Zoom out a little bit, we get neurogenesis and aptogenesis, which has a large amount of the antidepressant effects of these medicines. Zoom out again, and the default mode network gets shut down. And we zoom out again, and when the default mode network gets shut down, that puts me into my observer self. And what I mean by that is it's kind of like I go from first person to third person. If there's therapists listening right now, which I hope there are, that there's a type of therapy called internal family systems where it's kind of, this would be true self. This would be all my parts are kind of quieted because my parts are associated with my default mode network, but my true self now has access to all parts of my brain and all parts of consciousness. And this is also where our inner healing intelligence is. And what I mean by inner healing intelligence is the best way I can describe it is this. If let's say I cut my arm by accident, and since my mom is watching right now, I will say I have this scar here because I cut my arm right there when I ran through a glass window. Let's say I need to get like 13 stitches, and I go to the hospital, they give me 13 stitches in the ER, they tell me to come back 4 weeks later. I come back, they take the bandages off, take the stitches off, and I'm healed, right? I'm healed. Well, the stitches didn't heal me. My body naturally knows to send cells there to fight infection. It knows naturally to send cells there to reinnervate the area, to form new tissue. It knows to send cells there to form a scab. It knows to send cells there to bring the parts of my that have been cut together. My body naturally knows what to do. And this is what our inner healer, there's kind of an emotional equivalent of this. So when we are in a psychedelic state, our inner healers can kind of find our way. They can find meaning to issues that may have had other meanings at other times of our life and kind of reassign things by looking at them in a different way. And that's essentially what psychedelics are. They are meaning-making medications in which we find a way to kind of heal ourselves through the meaning that we can apply to them. So this is just some aspects of the psychedelic experience. And I'm not going to go through this except to say part of a lot of people's psychedelic experiences is people can have a very spiritual experience. And that is whether the experience is mystical or not, has been one of the best predictors of the antidepressant effect of a medication. So I just thought that's kind of interesting. And all the studies that are out there, that seems to kind of pop out. The more mystical an experience is, which is usually at some of the higher dosages of these medicines, the more effective the treatment is. So what are we really trying to do here? These are the medicines. We talked about how they work. We talked about kind of our inner healing intelligence. In therapy, what are we trying to do with patients? We're trying to get them unstuck with their thinking. We're trying to get them to quit isolating, call their friends, separate from their anger. Mindfulness is a big aspect of therapy now that's been found to be very helpful with, it's the power of now. Be mindful about the present because, depression is in our past, anxiety is in our future, so if we can be present in the now, it's a lot easier to just kind of exist. Practice gratitude, pay attention to your mind, body, and spirit. As therapists, we're always working, and patients, we're always working to take down our ego defenses so that we can address things that aren't so, don't feel so threatening. We're always trying to reframe and redefine meanings for things that have occurred in our lives. And, we're also trying to tend to our body and get outside and exercise. And I think this is, I put this slide in here. So therapists are simply the facilitator for our patients to discover this on their own. Because I'm aware that things are much more meaningful in the therapeutic process when the patient kind of comes up with an idea on their own. Anytime I say something, I guess there's like a hierarchy here. Like parents can't say anything to their kids. Kids don't listen to parents. maybe they listen to their therapist, but when they come up with the idea on their own, it means something to them. So again, these are medicines where people can come up with the meaning on their own and they find their own way, which is kind of a neat thing because I will say, having done this work now for 6.5 years, I'm always amazed at how hard I'm working in my normal private practice to kind of help nudge folks along and help people find meaning. Whereas in more of the psychedelic aspect in the ketamine practice, people find their own meaning. It just happens. I remember I had a patient once, and at the end of the session, he said, and they made me cry because it was really kind of a meaning. It was really a touching moment. It had, if I kind of explained the whole case, but he essentially came out and said, I was like, how was your experience? And he kind of came out of the ketamine experience. He said, I got divine permission to be myself. And I was like, sorry. This is a really cool guy. And so I was just like, wow. And we joked about it later on because I thought to myself, how long would it take me in therapy? And how much money would this guy have to spend in therapy to get divine permission to be himself? I couldn't do that for him, but he was able to do it for himself. So attributes of psychedelics, if we kind of go back to that other slide and we think about what we're trying to do in therapy, and we think about the attributes of psychedelics, they increase our sense of openness. They increase our sense of unity and connectedness. They increase our connection to nature, and they put us in perspective and help us realize that we're part of something that's bigger than ourselves, that we're part of this planet, and we need to take care of not only ourselves, but our planet. MDMA is really good at increasing connection to others. It can create like a childlike curiosity in people. And in fact, this isn't just kind of a saying like childlike curiosity. The brain of a child looks much more similar to the brain of an adult on psychedelics than it does to the adult, because the brain of a child isn't as organized yet. It's not till later on that default mode network starts to kind of grab a hold and simplify a lot of the things for folks. We have decreased fear because there's a part of our brain called the amygdala, which is our kind of fight, flight, or freeze area. And ketamine kind of shuts that part down and shuts down a lot of other parts, which is why it's great for treating trauma and such. And it's also MDMA is a great medication for trauma and PTSD because it shuts down that area, that fear center, but it leaves our cognition intact. We see ego dissolution, increased ability to reframe meaning, profound insight, desire to share the experience, and oftentimes the desire to take better care of ourselves. So these attributes of psychedelics really parallel what we're trying to do in therapy. And for that reason, they're great medicines, really good medicines, low side effect profile. They're not something that we have to take every day. We can take them and have an experience and kind of move on with our, integrate it and move it on with our lives. So, a lot of people kind of ask me, well, which psychedelic is right for me or my patient? And my answer to that is the legal one. Unfortunately, right now, ketamine is the only legal psychedelic in all 50 states. Portland just legalized psilocybin for its use in therapy, which is kind of a cool thing. Some of these medicines are being decriminalized in places across the country, but that doesn't mean that you can't lose your medical license for giving them. So even though something's decriminalized, that doesn't necessarily mean it's legalized. And I just kind of, I just kind of throw this in there, like there are now university major research centers like Johns Hopkins, UC Berkeley, Mass General, which is Harvard, UCSF, Imperial College of London, that have research centers dedicated to these medicines and dedicated to researching these medicines. There's even, I saw this recently, this is the Handbook of Medical Hallucinogens, which came out in 2021. And the important thing here is it's put out by the Guilford Press. And anybody in the mental health field knows that the Guilford Press puts out a lot of our, like, above ground books. These are the main people. So it's not like these medicines aren't, it's not like they're all underground. These are mainstream medicines that are being researched. These are medicines that are being written about. It's just that they happen to be illegal right now, with the exception of ketamine. So if I did have to answer that question, though, which one would be right for me? I think MDMA ultimately is going to be the ultimate. It's like a super robot for like PTSD and trauma. It's a really, really good medication for that. It's also really good for couples work. I think ketamine is a great medicine for depression or getting somebody out of a funk really quickly. For the past 6.5 years, I've seen that happen. It doesn't work for everybody. It works in about 50 to 70% of folks, probably closer to the 70% side than the 50% side, which again isn't everybody, but it's much more than that 30% with one, that we saw in that STAR-D trial with our SSRIs. And I think psilocybin and LSD are going to kind of end up being the medicines that we use for depression, anxiety, OCD, and there's a lot of good evidence with those in cluster headaches right now. I was going to end just this part with, this is kind of my ode to Raquel Bennett, which is she's kind of this pioneer in the ketamine community. And I love her because she'll give an entire presentation in the form of questions. So, so that's kind of what this slide is. The question is kind of, what does psychedelic psychotherapy look like? And that is still we're trying to figure that out. I think we have some models in the ketamine community, but even those models change. It's being used a lot more with ketamine-assisted psychotherapy, which is really where we're seeing it being most effective. However, I do think ketamine also sometimes, especially in the Southeast, with this demographic, people are sometimes tired of talking. They've seen their psychiatrists, social workers, psychologists, and so sometimes ketamine can do the heavy lifting and help people get back to their lives. But anytime you combine a medicine with a therapy, you're always going to get a better response. But how do we make these therapies, how do we make them available to people across all socioeconomic demographics? They're not cheap medicines, or it's not cheap therapy. They require a lot of time. Who's going to be doing the treatment? Is it going to be a therapist, a psychiatrist, or just a guide? And out in Portland right now, they're not requiring psychiatrists to prescribe psilocybin, and the people that will be leading the treatment aren't necessarily people with LCSWs. It's going to be people that are going to go through a course on how to lead this treatment. So what is their background? How do we fit it into existing medical models? Because these treatments are 6 to 8 hours. Ketamine is the one that fits the closest because it's a 40-minute experience. But even that, it's not just 40 minutes. It usually takes about 1.5 to 2 hours by the time you're kind of getting through it and integrating a little bit. All of these medicines, it's really important to integrate the experience afterwards. That's how you get the most out of it. The costs can be prohibitive at times. Do we do these in the office or a retreat setting, individual versus group? And I put down here the ethics and big pharma versus sacred medicines. There's something going on within the psychedelic community right now because people who have had experiences with these medicines, they're sacred experiences oftentimes, and they're meaningful experiences. I think we've seen that in the research where a large percentage of people will say this is a top 5 most meaningful experience. And right now, big pharma or corporations or companies are trying to kind of form to figure out a way to do this and kind of mass produce and make a lot of money on it. I don't fault them, I want this to get, to the public, but these are sacred medicines. And so how do we keep them that way for individuals? So these are just good questions to ask about things as we move forward. And I'll just kind of end with this. Your assumptions are the windows to the world. Scrub them off now and again where the light won't come in. So I'll end it there. That's my scrubbing bubble.
Thanks, Dr. Barton. That was incredibly great overview of psychedelics and where it stands and some of the potential impacts. So we had some questions coming in. Particularly, there was a question from Donna about the effectiveness with Alzheimer's. Have you seen, read, experienced any of this in relation to Alzheimer's?
So I don't know that. I will just say I don't know that research very well. I will tell you that's based on the potential of these medicines for that neurogenesis and synaptogenesis to cause the birth of new neurons and the creations of connections between neurons. So as we age, we think about dementia as kind of a rapidly declining cognitive status, but it's declining. We all get some form of dementia as we age because our brains are just shrinking over time. People with Alzheimer's and other types of dementia, they'll get it more rapidly. And so I think the questions around that research are, is there a way to kind of essentially create new neurons, grow new neurons and connections between neurons to help prevent against that? But to be honest with you, I don't know that research very well.
Excellent, thank you.
Yeah.
So Joanna asks, would a subject be able to, and I think we're talking about, well, never mind, I'll just read this question. Would a subject be able to engage in a therapeutic session with psychedelics, but still be actively taking antidepressant medication?
Yeah, so that's a great question. And what I would say with ketamine, absolutely, because remember, ketamine affects the glutamate system, and our antidepressants affect serotonin, norepinephrine, or dopamine. So there's no really cross interaction. If a patient is trying to do a psilocybin or LSD session, then an SSRI would interfere with that because they're competing for the same receptors, that 5-HT2A receptor. If a patient is trying to do an MDMA session, the medication would, most of our medications would also interfere with that as well, because serotonin and MDMA would compete for the same receptors. And if they're taking a dopaminergic medicine like Wellbutrin, that might be, if they were to take that with MDMA, that might be overstimulating because MDMA can have a very stimulating effect as well.
Rhonda asks, are there specific medical conditions that preclude a referral for ketamine treatment?
Was the question medical conditions? Is that what you said?
Medical conditions.
So there's two things that we worry about with ketamine. One is problems with breathing and the other is your heart. But usually that's not an issue. If somebody has high blood pressure or something along those lines, if it's controlled, it's not an issue. Ketamine causes an increase in blood pressure that's equivalent to basically like running up 2 flights of stairs for about 20 minutes. And that's about it. That's about the main side effect of ketamine. And just because it is a dissociative anesthetic, if somebody had pulmonary issues that were ongoing and acutely kind of problematic, that would potentially be a rule out as well. But in general, there's not many medical conditions that would include the use of ketamine as a potential treatment. And to that, I will also add, I think when we started this and we hear the word treatment-resistant depression a lot, because that's, anytime we get a new treatment, we're always wanting to help out those folks the most because they've been suffering the longest. And I think when I started this, that those were the types of folks that I was treating with ketamine. But, over time, we see that people want more choices with the types of treatments that they get. And sometimes people don't want to take a medication every day that has side effects like sexual side effects or weight gain and things of that nature. And so I think some of these medicines over time have become increasingly more of it seen as an option as opposed to the last option.
So Martha asked, I have a substance abuse program. I have many individuals with co-occurring diagnoses such as PTSD and ETOH.
Alcohol problems?
Yeah.
That's what that means, yep.
Oh, okay. Sorry. Non-clinician here trying to figure out
That's all
all these
right. I'm
things.
with it. I'm with
Would
you.
there be an issue with treatment in this group? Are drug screens given to ensure that there are no overlapping drugs? So I'm assuming with your experience in the legal option that we've talked about is ketamine.
Yeah,
Uh,
so and I'm glad she asked this. And essentially, if I'm hearing the question correctly, I can't speak to the urine drug screen. Usually, like a urine drug screen is you would have to test specifically for ketamine. But I think the issue that she's kind of asking about a little bit is like these are medications that are sometimes thought of as drugs of abuse. And I'm not saying that somebody can't abuse them. We can abuse anything. Somebody can go out and abuse LSD, they can abuse psilocybin, MDMA. Usually it's in a club setting, it's usually at an event. It's not usually something that they do every day. And in fact, many of these medications have kind of like almost like a built-in addiction prevention, because if I use psilocybin one day and I have this great experience and I want that happens on a Monday and I want to repeat that on a Tuesday, it doesn't work as well. So if I try it again on a Wednesday, it's really not working at all. So there's a required amount of time that our neurotransmitters have to kind of get replenished. And then the other cool thing that's happening is not only are these medicines uh, that we've thought of as, oh, these are drugs of abuse, they're not really getting abused that way. They have built-in addiction protections, but they are now getting used to treat addictions. And we're seeing that with ketamine a lot. There's uh, this concept called maladaptive reward memories, where basically if I have an addiction and I'm getting triggered by something, the memory comes up, it's out there kind of in the open, and then it gets reconsolidated and then gets put back down. And so when that memory comes up, it's susceptible to ketamine in this case, because glutamate, which ketamine hits, uh, is kind of glutamate is associated with memory and how we consolidate memories and stuff like that. So what's happening is they're working with people and getting people triggered right before the session, and memory comes up. You give the medication, and the memory gets not reconsolidated in the same way that it does with addiction. And so people are having a lot of success with things like cocaine addictions and stuff, where essentially we're seeing like decreased days of heavy use, decreased volumes when people use, and then increased time between relapses. I actually did this, it's just kind of a little experiment. Yesterday, I was working with a patient. He said I could talk about this, and he's totally obsessed with all the stuff going on with stock market and GameStop right now. And so he's checking Reddit like literally like 8 hours a day. And so right before his session, we pulled out his phone, and I just kind of triggered the crap. I triggered the crap out of him. I was like, okay, we're going to go to your Reddit page, but you can't read anything. You know, you're going to sit there and just and he could feel it kind of welling in his body. And then we gave him the injection, and I talked to him today, and it's bizarre. I mean, he hasn't looked at it in 8 hours a day. He's been spending on this, and he hadn't looked at it at all. And kind of when he did, kind of because he's scrolling through things and seeing like GameStop little news feeds come up, and you know, he's going past them and he's trying not to look at them because he's feeling like a different type of meaning and feeling guilt that he's not tending to his family when he's looking at these things. And so again, the meaning has changed. It's really cool stuff, really cool stuff. It's exciting.
kind of mentioned memories, but Beth asked, do any of these psychedelics pose complications with repressed memories? Like, I know you talked about in the observer role, you're able to access and observe, but
Yeah,
thoughts on,
that's a great question. I don't know that I have a great answer for that. What I can tell you is that psychedelics don't necessarily unveil repressed memories. It's not like every time somebody kind of reaches a higher level of consciousness, a repressed memory will come up. I can't tell you that a repressed memory wouldn't come up during a session, but what I always tell people during their sessions is don't run from it. Be curious, because the experience that you may have with whatever kind of difficult time comes up may be different from what it was before. So for example, let's say I was mugged, and every time I think about being mugged, I have a lot of shame and I feel like a victim, and I feel like, oh, I shouldn't have walked out at night in the middle of Chicago to get a piece of pizza because I put myself at risk and my family at risk. Maybe I think about that during a psychedelic session, and and instead of thinking about it with shame, I think, you still have your job, you still have your family, and you've made it through like one of the hardest events of your life, and you're still standing. Like, good for you, man. And so now it's kind of I've applied this different meaning of empowerment around this. Like, yeah, I got mugged and I made it through it, as opposed to thinking about, well, I got mugged and I feel a great deal of shame about it. So, I think again, one of the adages in psychedelic work is you trust the medicine. So if something were to come up, I trust the medicine that person's inner healer will find meaning. And again, if it comes up, it's material to be used in the therapeutic setting.
Thank you for that. So there are a bunch of questions around ketamine dosage and how it typically works. And I want to make sure that's a lot of your experience the last 6.5 years, particularly. Um, can you give us a quick overview of ketamine and how it typically works with your patients?
Yeah, so there's kind of two styles of ketamine treatment. One is more of a treatment more aimed at uh, kind of working towards getting at somebody's depression. And that's usually 6 treatments over the course of 2 weeks, or 6 treatments over the course of 3 weeks, something like that. And we usually do it on a Monday, Wednesday, Friday sort of schedule. The sessions themselves, where the people are under the influence of the medications, that last about 40 minutes. It's a ketamine is a dissociative anesthetic with psychedelic properties, so people typically feel outside of themselves. Ketamine is a treatment, if you're in the therapeutic community and you know about internal family systems, where we think about ourselves as being parts and then there's our true self. Ketamine is a really neat medication for that because it quiets our parts and it puts us in our true self, or kind of our essence. And so we're able to kind of look at aspects of ourself that uh, without being blended with them so much. And so I think every kind of medication deserves integration if the person is open to it. And certainly we try to do that here in working with folks. But there's also kind of another model of ketamine where it's more kind of a 3-hour sort of thing where we're working with the patient and sitting with them the whole time and kind of seeing them through their experience and really integrating the information afterwards. That happens usually with less frequency and is kind of just more dependent on a case-by-case basis. But a lot of times, I always think it's interesting because like my friends out in San Francisco, there's like 3 ketamine clinics with like five like ketamine assisted psychotherapists in each clinic, and they're full with like waiting lists. In the Southeast, we don't see it. We don't see these medicines that way. We see them more as like these traditional medicines where I go in for a procedure and I receive this. At least that's kind of what my patients. I'm speaking more to how the patients see these medicines. But they have a lot of potential to combine with the therapeutic process to get at some things that have been very difficult to get at previously. But they also have ketamine specifically has a lot of ability to do some of the heavy lifting. And so there is a population of folks that want to get back to their lives. They're tired of talking and they want to get back to their lives. And so we try to get them feeling better so that they're able to do that. And in terms of the details of it, I do have a website. It's nashvilleketamine.com. And you can go on there in the frequently asked questions section. I try to answer most of the questions that people ask me about ketamine. So that's a really good resource just to find out some information if you want some more details.
Yeah, I put nashvilleketamine.com into the chat here, so you can click on that. And we're at the top of the hour, Dr. B. Thanks so much for sharing your expertise and this great overview about psychedelics. And based on some of the research, hope that some of these, there's some reconsideration about the legality of them soon as their
Yeah,
effectiveness for treatment.
and to that, MDMA is supposed to be, the FDA is supposed to approve for legal use either at the end of this year, but because of COVID, it may be in 2022. And then I think we'll see psilocybin be about 2 to 3 years after that. It will legally be approved, but some of these medicines are being decriminalized in places and being made available. So it's pretty cool. And a lot of people will ask me about where can I find these treatments. And again, I only work with ketamine, but there's an organization called MAPS, which Rick Doblin at the beginning of I showed you a picture of him. Yeah, that's MAPS. I think it's maps.org, but it's the Multidisciplinary Association for Psychedelic Studies. And they oftentimes will list where these research studies are being conducted and whether they're taking volunteers or not. So that's a way that people can get involved with these types of treatments in a legal way.
Hey, one quick question, and
Yeah.
because your work with Integrative Life Center in Nashville, I want to make sure and ask this, but I missed. There's over almost 200 people in that webinar this entire time, so it's impossible to get to everybody's question.
Welcome, everybody.
Yeah, I didn't tell you that until just now, by the way.
Yeah.
There was over 500 that registered. So, big topic, but I know because you work with ILC and you've done that prolifically with Holly Cook, Chief Clinical Officer and co-founder at ILC, the relationship with ketamine work and substance abuse addiction. Can you give us some quick thoughts on that while we have you?
Yeah, and again, I think so. I had spoken to kind of those how ketamine can affect the way that we encode our memories, and that's really how it works with addiction. But the thing that I would say about ketamine, and it works so quickly, and when I say quickly, I mean it can be effective in as quick as like 72 hours, whereas most of our medicines take 3 to 6 weeks to work. And I always think like when somebody's going into a residential treatment facility like ILC or some of the other ones around the country, they're there to do the work. But a lot of them go in really depressed. And so it makes a lot of sense to think about these types of medicines in conjunction with that treatment in a parallel way to kind of get them out of their funk much more quickly so that they can kind of engage the services that a place like ILC offers and be involved in the group work and be involved in their individual work and not feel like they can't get out of bed. So really, I think kind of ketamine, because again, it's the legal one, as a way, as a kind of an early intervention for people coming in is important. And at ILC, that's one of the things that we offer, so that people can get involved in their treatment much quicker than sometimes waiting 3 to 6 weeks for traditional medicines to kick in. So ILC has been very open about that and working with me around that because it's something I believe in a lot, and I think it's helpful for the patients there.
Dr. B, thanks so much. IntegrativeLifeNetwork.com is where we ILC host these types of expert series. And Dr. Barton, this has been an excellent overview of psychedelics approach to all that and how some of the background research. So we appreciate again your time and sharing your expertise so openly.
It's always fun sitting with you, Cory.
We got to do this again.
We should.
All right. Thank you, Dr. Barton.
Yeah.
Have a good day. Everybody, thank you for being here.
Hey, and just man, I'm happy to answer if other people have questions they want to. I'm happy to do that. But if you need to go, that's fine too.
Okay. Well, there are a ton of questions here, and I'm sorry, everybody. I'm trying. It's just I think there's 35 open questions right now. Let me look through here. Sarah asked, does ketamine affect the manic phase if suffering from bipolar?
Yeah, that's a great question. That's a great question. So ketamine is unique in that it doesn't typically flip people into a manic episode. So if you do need an antidepressant for the acute phase of a depressive episode in somebody with bipolar disorder, you can use ketamine because we just don't see it flipping people into mania. That's not the case with some of our other like SSRI medications, which historically have the potential to flip somebody, especially if like a mood stabilizer isn't on board.
Okay, thank you.
And I'm just kind of glancing at these questions.
Yeah.
And one of them is, what about the contributors to this field who aren't white men? Indigenous cultures, as an example, have been using psychedelics for healing for thousands of years. Acknowledgement of that fact might be helpful in the future. I couldn't agree more. And that's what I was giving a little bit of a referral to that when I was talking about these are sacred medicines. Indigenous cultures have been using psilocybin. They have been using ayahuasca for hundreds of years. And we owe them a great deal of acknowledgement and thanks for helping kind of teach people about these medicines. The other thing about just having a diverse community of providers, that's a problem, and it's something that is being worked on within the psychedelic community. There's a lot of people who are working on this specifically, but it's not an easy answer. But it is something that is noticed. So I do appreciate that person saying that, because that's something that I'm aware of as sitting here as a privileged white male, and so I think that I just wanted that person to know that I'm not ignoring that, and I'm not ignoring the kind of indigenous cultures that have provided this. This was just more of a talk about how these medicines are being used in the mental health community right now, and less of the kind of sacred shamanic use of these medicines. So I just wanted to kind of let that person know that I appreciate that comment.
Yeah, thank you for that. So there was a question here, and you and I have talked about this offline, but ketamine administration, I said IVs. Oh gosh, I faint. When I can take a shot anywhere except for right here. But you said there's other options. What other options for ketamine specific administration are there?
Yeah, so there's actually there's a legal, or I should say not legal. There's an FDA approved version of ketamine, which is Spravato, which in my mind is a good medicine to help kind of get people from booster to booster sometimes, but I don't think it's as effective as either the IV or IM version. And when I say IM, I mean the injection. And so I think when I started my clinic, we gave everybody IV ketamine. And what we did that because that's what the research papers were doing, and I was trying to emulate what the research papers were doing. But what we have found over time is that the injection form is just as effective as the intravenous form. And so at my clinic, we try mostly to do injections, and because my main kind of goal is to kind of have the patient be relaxed, and I think being hooked up to an IV is not always the way to do that. I share in your kind of IV phobia, and so if I have an IV, that's what I'm focused on, and I'm not relaxing, and so it is kind of a neat thing that we're able to give injections as opposed to kind of having somebody hooked up to an IV the whole time and it be equally as efficacious.
Yeah, you don't use as much the lozenges as I recall, because those have some in it.
Yeah, that's kind of an interesting thing, because a lot of people 2 years ago, people would say, you have to be in the office for this to happen. Well, COVID hit and people weren't coming into the office. And so there was a question of how do we deliver ketamine to people when they can't come into the office? And so a lot of people will use lozenges or troches. And there's some friends of mine who work at a clinic called Polaris, and they do a lot of like telehealth sessions. And again, 2 years ago, we wouldn't have thought of that, but they've been able to do it effectively, from what I'm told. At my clinic, we do in person, and that's not to say that theirs doesn't work. It's just to say it's just what fits my personality and my style. I don't use the troches as much, which is an oral disintegrating tablet of ketamine. I occasionally will use that mainly for like people if they're coming long distances or something of that nature and they can't, it's hard to get here. But those medicines, the oral version in my mind is best suited for the ketamine assisted psychotherapy because you can't necessarily get to the higher dosages without having like multiple tablets in your mouth kind of dissolving, and it's just not a fun experience. I think those are better for the ketamine assisted psychotherapy. I think the IM versions or the injections or the IV versions are better to kind of get people out of the funk and are kind of the best for the in-office booster, so to speak.